to this room, and a special welcome to the Ambassador of Indonesia to Sweden, Mr. Sastrawan and Mrs. So I'm going to talk about big data and public health. So talking about data, this was my first computer back in 1985. I didn't know that this looked quite similar, otherwise I could have taken that off. It's kind of the same color. But when I got this computer, I worked with Word Star. I think many of us remember, there was no Microsoft Word before. It was only Word Star. And then I got this from my parents. Does anyone remember what this is called? Floppy disk. I think my daughter, they do not know this at all. And when I give this to them, they start playing like this. So back in 1995, I got the chance to do a small study for my undergraduate thesis. I studied the outcome of treatment of leukemia among young children in a hospital in Indonesia, in a province in Indonesia. So I went through all the medical records because there were no electronic medical records. All the data were on paper. So I went through about 400 records and I spent 4 months just to get those data. And in 2003, I got another opportunity to do a wider scale research on 3,000 individuals aged 15 to 65 in a district in Indonesia. I studied the chronic disease risk factor. So we spent quite a lot of time planning for the research. We spent quite a lot of time collecting data. We go to individual households. We went to individual households. We asked people about different things, about their health, about their socioeconomic status. We also measured their blood pressure. And we also took register on birth certificate, for example, marriage certificate, and so on. So that took us a lot of time, from data collection to data analysis and, of course, data interpretations. Until the time when we went back to the people, we went back to the district health office to communicate the research back. It was already 2 years. And again, in 2006, based on the finding of that study, we understand that smoking was a significant problem in Indonesia. It's one of the countries where smoking prevalence is very high. You believe it or not, but about 60% of Indonesian males smoke, unfortunately. And a lot of them are going to die because of coronary heart disease, of diabetes, of stroke in the near future. So we conduct a study among physicians and patients. So we asked physicians whether they smoke or not. And unbelievable, 22% of the physicians in the teaching hospitals smoke. So we thought, if physicians smoke, then it's not possible for patients to quit smoking. So then we select a sample of patients to study their smoking behavior. We decided to go for TB patients, tuberculosis patients, because we know that if they have tuberculosis, it's very difficult for them to breathe, not to think of smoking. So we asked them, did you smoke before you got the diagnosis? Did you smoke when you had the diagnosis? Did you smoke when you were in the treatment, between 1 to 3 months, 4 to 6 months, and after the treatment? And we got these quite astonishing patterns. About 67 of the patients smoked before they got illness. That's confirmed our finding in the population. Over 60% of Indonesian men smoke. And I have to say this is only among men. And when they got the illness, only 10% of them smoke, which means that a lot of them quit smoking because they could not smoke anymore because of the illness. But it's quite amazing. They keep quitting until the 3rd month of the disease, the treatments. But when they got better because of the treatment, they resumed their smoking behavior. And 12 months observation, 6 months after they finished their treatment, about 1/3 of them resumed their smoking already. So this is really a significant problem. And when I moved to Sweden in 2007, I got a chance to work with this big data set, Fasterbotten intervention program. It's an ongoing health examination among people 40, 50, 60 years old in this county, in this very county. It started back in 1990, even though historic was a bit earlier. But in this data set, I have analyzed 140,000 people or examination from 100,000 individuals. Because people were invited when they turned 40, 50, and 60, which means that people who came when they were 40 years old, they would be invited again then when they were 50 years old. And I would like to highlight that the same thing research instruments, questionnaire, and also what is impressive in this study is how the research are being communicated back to the people or to the patients. And this is the star profile, if we see over here. So this is how nurses in a counseling session give the result back to the patients. They try to make the star a full star from this different risk factor profile. For example, a patient has very low physical activity. That specific patient does not have any shape on that part. So the idea is that a healthy patient should get a full star. While patient with a lot of risk factor, they will have a star which looks like has been hit by a meteor, for example. So maybe in the follow-up, they improve their physical activity. So instead of 0 on the scale, they got 2 on the scale over here. So the idea is that over follow-up, patient improve their risk factor profile and they get a full star. And I think this is brilliant. This is a very easy way to communicate the research back to the people. So I'd like to highlight one risk factor, cholesterol levels. So we published this back in 2012. This graph shows the cholesterol patterns or cholesterol levels among men in blue and women in red in this Ferry County based on the data. So the cholesterol level was quite high in the beginning, in 1990, but then it decreased and it reached a plateau by the year 2000. But something happened by the year 2007, 8, 9, and 10. When we published this data, we only got access to the data up to 2010. So we were questioning what could possibly happen, that it seems that there's an increasing trend of cholesterol. And now I have to reanalyze the data and put in 2 more years. And it seems that something is happening in this county. So we are talking about data now at individual levels, but at the county level. So every day when I wake up and I dress myself up, try to go to work, I always think, God, I like my job a lot. I'm an epidemiologist. Because every time I see that a lot of people actually agree with me that less is more. That's how we do the research, because of very much research constraints. When we are doing research, what we are trying to do is to collect as less as possible, but as much information as possible. So less information, high quality, targeted information. But if we're talking to a data scientist, epidemiology, a big data scientist, I think for them, more is better. So what is actually big data? I'll spend the next 5 minutes to talk about big data. It's a data of very large size, typically to the extent of its manipulation and management, that it presents logical challenges. So it's huge in volume. It's not possible to put it in this. This cannot even take a photo if you take a photo with your mobile phone. And not even, I think I have this, if you still remember also. This is the brother of this. Not even to the even younger brother. If you have a USB stick, for example, this takes 8 gigabytes. And that's not the size of big data. It's big, big, and big. And it differs in variety. When I did my study in Indonesia, we spent a lot of time to prepare the study, to have good instruments, to have good protocol. We train people to collect the data, but with big data, anyone can contribute to the data. So it has some data are being structured, some data are being unstructured. And it's very high in velocity. It's being created in time or in real time. And it's covered probably the whole population. So may I see everyone handphone? Not hand, but your handphone. Sorry. Of people in this room, how many have used the handphone this morning? Almost everyone, I believe. So when we're talking about big data, we're talking about data of probably soon yottabyte. And this one is probably at a gigabyte. So it's huge in volume. And why big data grows so much? Because of internet. By this year, 42% of the world population have access to internet, with a huge variety from 81% in Europe, 69% in Oceania, 88% in the US. But remember this, 26% in Africa. And look at China, for example, almost 51%. And out of those internet users, a lot of them are using social media. So 7 billion world population, about half of them use internet, about 2.2 billion use social media, and quite a lot of them have social media in their mobile phones. Can I see hands who have social media in the phone? Any of these, or any typical other applications? So actually, by today, we are not the object of research anymore. We are the data generator. We are generating data, and we contribute to the generation of the data every day, every minute, everyone, old, adults, children, and unfortunately, yeah, but if you live in Taiwan, if you let your children to play iPad before they were 2 years old, you will get a fine of 1,000 pounds. So they have now put a new regulation. Children are not allowed to play iPad until they are 2 years old. So basically the message is that the research scope changed quite a lot from traditional research to big data analysis, because we are contributing constantly, generating the data. So when I did my research, or when every one of us do our research in our respective field, we try to collect data on very limited sample. But with big data, it's the whole indefinite populations. Everyone in the world, a farmer in Africa, they can contribute to big data with their mobile phones. A rickshaw driver in Indonesia, they do so also every minute. And when we do traditional research, we have very strict protocol. But if you like your Facebook friends, there's no protocol, you simply click like. So, and when we do research, we strive for exactness, exactitudes. But with big data, we tolerate inaccuracies. When we do research, we use a lot of resources, but with big data, it tends to be more economic. But this is an interesting point. If we do a research, from when we design the research until we disseminate the research, it takes years. Do you agree? But with big data, you can key in the results now and you can get the data now. So almost real time. Which is more important here is that as an epidemiologist, I'm very interested in causation. What caused what? That I can do with small scale data. But with big data, it's quite impossible to understand causations. What we can learn is to understand different patterns and correlations. So I will illustrate, this is the way epidemiologists work. This is probably not so much an epidemiologist. Do you know what is it?
Yes.
I took this in our unit. So if people see things like this and they know that it's Nawi Ng's week. So when we talk about big data, it has been exploited a lot by business sector. If you go to Amazon, for example, if you try to find Harry Potter books, and then you click Harry Potter and you click on, and then you scroll them up, you see that it says, customer who bought this item also bought that. But how do they know that? And we got that also almost constantly. So what can big data do for public health? We can use it to monitor population health status, we can evaluate interventions, we can conduct research, and we can try to improve efficiency and quality of public health services. So quite a lot of things that we can do with big data, which actually we can do also with smaller scale data. So for example, Twitter has been used to provide early warning system for earthquake. I believe if there's earthquake now, everyone will probably get the phone and try to tweet earthquake, question mark. And that's how Twitter's analyze the responses. So on real time, and then they try to give some warning, because it has been shown that actually tweets travel faster than seismic wave. As we tweet, it travels to the center and it's traveled far beyond the epicenter zones. And Google has also used the online data to try to predict epidemic of influenza in the US. And this was published or reported in 2009. So this is the real case. The black line is the real case, and the red line are the prediction from Google. In 2009, they were quite comfortable with this estimate. They said that we have predicted the flu epidemic. But in this year, last year was an article in Science. It shows that actually Google did not do a good job, because Google overestimates a lot of the cases. So for example, in 2013, Google almost estimated the cases as double compared to the Center for Disease Control estimates. So Google haven't really done a good job in using big data. And the very same authors, Lazar et al., coined this term, big data hubris. What it means, and I quote, implicit assumption that big data is a substitute for, not a supplement to traditional research. And I think the way we have to treat big data is that it's not a substitute for. We have to keep doing our own traditional research using all the scientific rigors, but big data can provide a bit further more information on what we are researching on. So quantity of data doesn't mean that one can give up the foundational issue of measurement and validity as well as reliability. So basically, if we have big data, it doesn't mean that we have good data. So that is the take-home message, I think. And if you go to the Google website now, Google just simply thank you for stopping by, we have stopped the service. So they have closed down the prediction, unfortunately, now. So one of my students also used this big data, and together with Associate Professor Joachim, who was sitting back there, we used temperature data in Singapore, try to predict dengue cases. So we have 3 lines over here, the dengue cases in black, the rainfall in blue, and the mean temperatures in green. So what the student did, she tried to use these temperatures and rainfall, try to predict when dengue cases happened. And she used the data from the year 2000 to the year 2010 to develop the models. And there are 2 lines over here. The black line is the real cases, the real observed cases. And the red line here is the predicted cases. So she used the right methods to develop these predictions. And as we see over here, the observed and the predicted cases, they are quite close to each other, right? So she used this 10 years data to develop the prediction, and she later used the prediction, or the model, to predict the cases which have not happened yet. So it seems that she has a very good model, which actually estimates 97% very accurate estimation of the outbreak. So again, this is the prediction, and this is the real cases. She could, for example, using this model, predict the epidemic of dengue in Singapore. So but the bottom line is that big data is good, but we have to use the right tools to analyze the big data. And in this very university, in Umeå University, we have the Center for Demographic and Aging Research, which hosts this big data. To me, it's big enough. It's called Linnear's database. It has all the data from the fast-abortion intervention program, which I described earlier. It links the fast-abortion intervention program with the Swedish National Register over here, the Statistics Sweden. So we know, for example, for everyone who participates in fast-abortion intervention program, we know, for example, their income back in 1980. We know their income every year. So one research question, for example, how is income inequality contributes to risk factor development? We know who their family members are. We can see whether, if someone participates in VIP, whether they have better risk factors among their family members. So I believe nowadays we get a lot of this to our mailbox. If we go to, for example, I just use ICA over here, we got a receipt, but then at the end of the month we got offers, you get this 20% discount of this product and so on. But then I asked my wife, how does ICA know that you bought all these items? She said, no, I did not tell ICA. But she did actually. ICA analyzed all this big data. So we actually have big data in this county. All these shop registers, shopping habit, we know our shopping habit. So for example, if you try to understand these differences and why this increase, couldn't we actually contact ICA and ask for the register during 2008, 9, 10, 11, and 12? Of course, we don't know who bought what, but what we can do is to analyze ICA data and split it by municipality. People who live in, for example, the city center, people who live in Umeå, people who live in Esboda, and so on. Try to see these, whether shopping habit actually relates to cholesterol patterns. So this is one exercise of big data also. So I hope with that exercise, maybe in the future, instead of going to Amazon and get customer who bought this also bought that, maybe in the next few years when we go to ICA or Cook or whatever, we'll see this also. If you buy banana, maybe you should buy carrot also, I think. So challenge of using big data, ethical issue. How many of us who have answered to this question without reading this? A lot of us. So we do not know what actually is surrounded to Facebook, for example. How many of us have used this kind of software, try to measure our exercise, our foods, our physical activity, for example, whether you cycle certain routes, certain kilometers per day. So all of these contribute to the big data, but there are also challenges because we need to have new way to analyze this data. Because unlike research data, these are very unstructured. This kind of data can come from anyone, simply anyone in the world. So I have a few take-home messages. First is that we need to improve our understanding on the ethical issue. We think that we want to use big data, but there are a lot of ethical issues related to big data usage. And one of the most important things is that we have to do research, try to translate the big data and use it for public policy making. And what is more important is that to educate the public in such, for example, way that they have to be open-minded, try to be critical that the quality is mixed. And I certainly want to embrace multidisciplinary research also, because if we only analyze the big data, it's only an exercise of crunching data. Without collaborating with people from other fields, it's not possible to understand what's behind the pattern. So though it has potential, but again, it's a supplement, not a replacement. And I think for the next few years, I'll enjoy my work analyzing almost big data. I'm not sure if I'm going to analyze Google data, but I certainly will invest a lot of time working with faster protein intervention program, working with Linneaus data, try to understand more from that. And at the end, I'd like to acknowledge the people, all of us, because we contribute to the development of the big data every minute. The Faster Protein County Council, Center for Demographic and Aging Research, my previous university, Gajah Mada University in Indonesia, my department, and of course my family. But last but not least, I would like to congratulate my kindergarten teachers, because without them, I do not know 1 + 1 is equal to. Thank you for listening.
Very much, Nawi, and I'm sorry we don't have any time for questions. But we thank you for a very nice lecture with big data and also big passion. Thank you very much.